Hello, I'm Dr. Brian Richman, podiatric physician and surgeon at Tanner Clinic in Layton, Utah. And today I'd like to talk about diabetic foot care. I see a lot of diabetic patients, and as you know, diabetes is a team approach, and there's many physicians, nurses, staff, and helpers that help with diabetic foot care. So with diabetes, there's complications like infections, blisters, corns, calluses, ulcers, burns, foreign bodies, gangrene, bony deformities, and amputations. First, I'd like to talk about diabetic infections. These are serious infections. I like to classify them as mild, moderate, or severe, and they need to be treated quickly and appropriately. On a mild infection, like maybe an ingrown toenail, usually we can take out the ingrown toenail and put them on oral antibiotics and we're okay. For like a moderate infection, say like cellulitis or with ulceration that's infected, a lot of times we'll have to admit the patient to the hospital, do an incision and drainage procedure, open it up and flush it out, and put them on IV antibiotics. More serious infections like sepsis, gangrene, those type of infections are very serious. We need to admit them to the hospital, do an incision and drainage procedure or possible amputation, and put them on IV antibiotics to get the appropriate care for them. Infections can go very quickly from minor to severe, so we want to catch them early. Signs and symptoms of infection: pain, redness, swelling, red streaks up the foot or leg, drainage, pus, odor, fever and chills, nausea and vomiting. So we start out with corns and calluses and pre-ulcerations. For example, if you had a corn on the top of your right second toe and had a hammer toe deformity, that could be irritation from shoe gear, from a bony prominence, and can develop into an ulceration. An ulceration is an opening of the skin which can go down to the bone, and the bone can get infected, and then the patient could lose their toe. So we like to correct these before that happens. Usually we'll do trimming the callus or trimming the corn, offloading the lesion, or possibly doing surgery. For example, in this case, like a hammer toe correction, we straighten out the toe and the corn goes away. Next, I'd like to talk about diabetic ulcerations, which we see quite a bit of. And these are, like I said, it's a breakdown of the skin, breakdown of the tissue underneath the skin, and can go all the way to the bone. And these are caused by many different things. They could be caused by pressure from a bony prominence. They could be caused by arterial insufficiency or venous insufficiency. They could be caused by trauma, like a blister or like a burn. And they're graded in different stages from mild to severe. And we treat those differently, but we try to treat them so that we heal up the ulcer and also prevent the problem from happening again. And there's many different treatments that we can do, but sometimes we take them to surgery and remove the bony prominence or whatever we need to do. Next, I'd like to talk about peripheral vascular disease. In our diabetic patients, peripheral vascular disease is caused by vasoconstriction of the vessels. Also, certain things like smoking, plaque or high cholesterol or hypertension, or things that clot the vessels can cause peripheral vascular disease. It can actually go to gangrene. There's two types of gangrene. There's dry gangrene, which is just necrotic dead tissue, and there's wet gangrene, which is a severe infection causing sepsis, where the patient could actually lose their life if not taken care of. So with vascular disease, we try to, one, help the vascular flow better by either with medications, or we refer them to a cardiovascular surgeon and he can do some revascularization procedures to help with blood flow. Next, I'd like to talk about diabetic foot amputations or leg amputations. It's unfortunate when this happens. We try to prevent these from happening, but sometimes people have like an ulceration that becomes infected, the bone becomes infected, which is called osteomyelitis, and sometimes we'll have to remove the infected bone and either do an incision and drainage procedure and clear up the infection. A lot of these go on to amputations, like a big toe amputation, which we call hallux amputation, or lesser digit amputations, which we call lesser toe amputations, like second, third, fourth, fifth digits amputation. Sometimes the infection goes to their forefoot, and we'll have to do an amputation called like a transmetatarsal amputation, where we remove all of the toes and flush out the infection and hopefully help this patient heal the amputation site with a plantar flap. Further amputations like show parts amputation is the midfoot amputation, and then you go to amputations like a below the knee amputation or above the knee amputation. And these are always usually caused by either vascular disease, gangrene, infection, sepsis, and we try to preserve as much tissue as we can and still have function and have the patient have healing of these wounds. Next, I'd like to talk about diabetic Charcot foot. There's acute Charcot foot. This is where the bones are breaking down because of the disease in the midfoot or the ankle. Or there's chronic Charcot foot. Chronic Charcot foot, everything sort of comes back together and we try to coalesces or fuses where it's at. But what happens with Charcot foot, the bones break down and there's not normal anatomy, and so you get what they call a rocker bottom foot, where the bones are actually coming through the plantar surface of the foot, or you get a subluxation or dislocation of the bones. This is a very serious disease and we need to treat this quickly and appropriately also. Sometimes we use diabetic shoes. Sometimes we'll go in and remove the prominent bone so we don't get an ulceration. Sometimes we'll actually go in and do a Charcot reconstruction procedure to try to put the bones in more correct normal anatomy position. I've enjoyed being a foot and ankle specialist and foot doctor for 26 years here in Layton, Utah. And I work at Tanner Clinic and I really enjoy my patients and my staff and the people that work at Tanner Clinic, and also the people that help me in the hospitals and other physicians that also help with our diabetic foot care. If you do have a diabetic foot problem, you need to see a podiatric physician regularly. Usually we see our diabetic patients every 2 months. Some people we do every 6 months, some people every year. There are 4 excellent podiatric physicians here at Tanner Clinic: Dr. Todd Flinton in Kaysville, Dr. Brooks Potter in Layton, and Dr. Gary Oakes in Roy, and myself, Dr. Brian Richman in Layton. So if you do have a foot problem, we are happy to see you or happy to schedule an appointment with any one of us. Have a great day. Thank you.